Hi, everyone. This is Podcast for Patients with the Aplastic Anemia and MDS International Foundation, and I'm Alice Hauk, Senior Director of Health Professional Programs. Our podcast series is brought to you thanks to generous support from patients, families, and caregivers like you, and a grant from Celgene. Thanks, everyone, for supporting the series. Today, we're talking about the recent approval of Luspatercept with Dr. Amit Verma, Director of the Division of Hematologic Malignancies and a Professor of Oncology at the Albert Einstein College of Medicine in New York City. Welcome, Dr. Verma.
Thank you, Alice. It's a pleasure to be here.
Can you explain the role your lab played in discovering the pathway for Luspatercept?
Yes, we have a lab that works in myelodysplastic syndromes and aplastic anemia. We are located at the Albert Einstein College of Medicine, and a few years ago, we started working on identifying the pathways that make the bone marrow in these diseases work not as well as it's supposed to. So, as you know, and as a lot of our patients know, the main problem for a lot of patients with aplastic anemia and MDS are the low blood counts. So the question is, why doesn't the bone marrow make enough cells, enough red cells properly in these patients' bone marrows? And we made the discovery that there is a protein called SMAD, spelled as SMAD, that this protein is very heavily activated in the bone marrows of patients with MDS and in some cases aplastic anemia. And we were able to show in a series of experiments and published papers that when the SMAD protein is high and it's activated, it prevents the stem cells from becoming red cells in a proper manner. So when you have very high levels of this protein, it causes anemia to happen. And this new drug, Luspatercept, that's recently been approved by the FDA, inhibits this protein, inhibits this pathway. This pathway is also known as the TGF, transforming growth factor pathway. And this drug inhibits certain growth factors that belong to this TGF family from binding to the stem cells and activating the SMAD pathway. So simply put, you can think of Luspatercept as an inhibitor of the SMAD protein activation. And that's what we showed in our lab. And we showed that when you block this SMAD pathway, the TGF pathways, you have better production of red blood cells. So just to summarize, Luspatercept is the new drug that's approved. Luspatercept blocks the activation of the SMAD pathway. Luspatercept blocks the certain members of the TGF pathway. And when you do that, you have better production of red blood cells in the bone marrow. And so this drug leads to higher hemoglobins, higher red blood cell counts. And a lot of that initial lab-based discovery work was done in our lab.
That's wonderful to hear. And we at AAMDSIF, we've supported some of the work in your lab with grantee, one of your colleagues, Britta Will, and we certainly have been following that progress. So we appreciate the research that's been done there and appreciate how long it can take, but it can lead to wonderful discoveries like Luspatercept. Tell us which MDS patients are most likely to benefit from Luspatercept.
Alice, firstly, I do want to reiterate that your support and support from others, foundations in NIH, has been extremely instrumental in supporting the basic research we have done. Britta is a close collaborator, and she was working on these pathways with us. So we truly appreciate your support, and that has really led to this work coming to fruition in the clinic. Okay, so back to the question. So which MDS patients are most likely to benefit? When they did the trial, the big phase 3 trial in the US and other parts of the world, they included patients with MDS with the type of MDS called RARS. The full form is refractory anemia with ringed sideroblasts. This is a subtype of MDS which belongs into low or intermediate risk MDS. So MDS can be lower risk or higher risk, and we call it lower or higher risk based on the risk of transforming to a full-blown acute leukemia. So RARS generally is of the lower risk subtype, and why we call it as ring sideroblast is when we look at the bone marrow, we see that this type of MDS has a very unique appearance on the bone marrow slides. You can find a ring of small iron deposits. That's why it's called ring sideroblasts. So that's a very technical way of identifying this particular MDS. But that's the patients with MDS that were treated with luspatercept in the phase 3 clinical trial. It was called the Medalist trial that was recently published in the New England Journal. We were one of the participating sites, in addition to all major centers in the US. And there is now another trial which is now evaluating the use of luspatercept in other subtypes of MDS, not just RARS. And we will know the results of this trial relatively soon. But for the moment, um, RARS subtype is the one that has been shown to derive the most benefit from luspatercept.
And what type of treatment were those patients that now will benefit from luspatercept? What might they have been receiving as treatment prior to this?
So that's a great question. MDS generally does not have too many FDA-approved therapies. Luspatercept is actually the first therapy approved for treatment of MDS after 14 years. And unfortunately, we only have 3 different drugs that are FDA approved for the treatment of MDS. 2 of them are very similar. They are Dacogen and Vidaza, basically very similar drugs, which are generally used more for the treatment of high-risk MDS. There is also this drug called Revlimid or lenalidomide that has been approved for treatment of MDS, specifically those that have deletion of chromosome 5. That's about 8 to 10% of all MDSs. Then in some cases, we use growth factors like EPO, erythropoietin, or Aranesp, but that's about it. So coming back to your question, most patients who get anemia, we try erythropoietin, EPO, or Aranesp, and if they do not work or if they stop working after a little bit of time, we rely on transfusions. So these patients, a lot of them are on regular transfusions, red blood cell transfusions. And unfortunately, we don't really have too many other things to offer. And now that luspatercept is approved, the hope is that some of these patients that are dependent on transfusions will be able to increase their hemoglobin on the drug and will be able to avoid needing these red blood transfusions so frequently.
Are there any risks to receiving frequent blood transfusions and also benefits to becoming transfusion independent?
It's a very good question. The major risk is the risk of iron overload. So our bodies have mechanisms to collect and store iron, but they unfortunately don't have a mechanism to excrete excess of iron. And every time a patient gets a transfusion of red blood cells, they also get a big dose of iron because the red blood cells contain hemoglobin, which has a lot of iron. So when you're getting repeated transfusions, there is a overload, an excess of iron that builds in your body. That iron overload can lead to damage in certain organs like the heart, like the liver, like the pancreas. And so iron overload can, over the course of time, lead to decreased heart function, can lead to decreased liver function, and is generally not a good thing to have. So that is one risk of getting repeated transfusions. The other risk, it's not really a risk, an inconvenience, is that patients need to get blood counts done, get type and cross done in the transfusion area, and then the next day they'll come and sit for 4 to 8 hours trying to get 1 to 2 units of blood. So it's severely disruptive to their quality of life. They basically have to make a trip to the clinic every week or every 2 weeks. And it's a big quality of life issue getting these transfusions. There are also some rarer risks, contracting diseases like hepatitis and all, but those were in the olden days. Nowadays, our blood banks are pretty good. So those are relatively less of a risk right now.
I see. And you mentioned the successful medalist clinical trial that showed the efficacy of luspatercept. Can you tell us about those trial results and why they were so promising?
Absolutely. So this was a trial which was recently published. This was done all over the world. And in this trial, it was a phase 3 trial. So patients were randomly assigned either to luspatercept or a placebo. And the endpoint that was evaluated was the ability to get independence from transfusions. And when we looked at the trial data, there were a total of 229 patients that were enrolled. 153 got luspatercept, 76 got the placebo. When you compare both these groups, we found that 38% of the patients that received luspatercept became transfusion independent. And this was in comparison to 13% in the placebo group. So this was quite a significant difference, 13% versus 38%. And this was the ability to not need any red transfusion for 2 months or 8 weeks. So that was the big endpoint that led to FDA approving this drug. There were also some secondary endpoints that also looked good. These included, higher percentage of patients in the luspatercept group that had increases in hemoglobin, and also the duration of the effect was significantly higher in the luspatercept group compared to the placebo group. Overall, we also look at side effects. Drugs are not innocuous, they come with side effects. And we did not find any serious, we call them in technical terms grade 3 or grade 4, any increased, serious side effects with the use of luspatercept. There were slight increases in fatigue, and a little bit of diarrhea, a little bit of nausea, but nothing that was that concerning with the drug. So in a nutshell, that's the overall results from this trial.
And are there any medical conditions that would preclude a patient from receiving luspatercept?
It's a good question. I don't think so. Patients with MDS are generally elderly. A lot of our patients do have underlying heart issues or diabetes or diseases that can accumulate with age, but I don't believe there are any red flags that will preclude the use of luspatercept in these patients.
And is luspatercept safe during pregnancy?
That's a good question. We usually don't face this problem, at least in MDS, because, like I said, most of our patients are, the age is not a reproductive age. I think that, it should be definitely used with caution in a pregnant situation, because these drugs do affect other organ systems. So at this point, I would be hesitant to use this in a pregnancy situation. I would avoid it.
And are there any fertility concerns for women or men who would be receiving luspatercept?
I'll have to look at the label to get the absolute technical answer, but I don't believe so. This drug was actually interestingly developed originally for osteoporosis. So when they gave this to volunteers, they found that their hemoglobin went up, and the development of this drug actually started happening in MDS and diseases with low blood counts like thalassemia. I don't believe that it has any known fertility effects at the present time. Now, as the drug is used more and more trials are done, we might find something more in the next few years. But so far, to the best of my knowledge, I don't think it has any fertility concerns.
And is luspatercept approved for children? I know MDS is extremely rare in children, but has it been approved for children, or is that something that may be considered in the future?
It's a good point. It's very rare to get MDS in kids. It is approved for the treatment of thalassemia, which is actually a disease that affects children and adolescents. So technically, the drug is approved for pediatric and kid populations, but for thalassemia. For MDS, it is generally, it's exceedingly rare to get RARS, low risk MDS in kids. When kids do get it, it's more of a higher risk MDS.
I see. And finally, do you have any advice for low-risk patients who are listening to this and wonder if luspatercept is something that they should be inquiring about with their provider if they have not done so already?
Yes, I think if we have subjects or individuals that have been diagnosed with MDS who are requiring transfusions on a frequent basis, they should definitely inquire with their hematologist whether they will be eligible to receive luspatercept. Right now, the label is, for lower risk MDS that are requiring transfusions, and the hematologist has to probably talk to their insurance to make sure that they get coverage for this, whether their type of MDS will qualify. And then I think it's definitely worth a shot, because I know how tough transfusions are, getting these transfusions week after week. And if there is a drug with minimal side effects that has the ability to raise hemoglobin, I think it will be a very beneficial thing for a lot of our patients.
Thank you, Dr. Verma. This is very encouraging news for so many of our patients, and we certainly appreciate the role that you and your colleagues there at Einstein and around the world have contributed to this work and the development of this new treatment option for MDS. So thank you again for your time today.
Yeah, thank you, Alice. Thank you and your foundation for all the support over the last so many years, and I look forward to being of any help in the future.
Wonderful. And thank you to everyone in our listening audience for joining us. You can find out more about bone marrow failure disease on our website at www.aamds.org, by following us on Facebook, Instagram, and Twitter, or by calling our helpline at 800-747-2820. Thank you again for joining us today.